Welcome to yet another story on Academia World. Today we are going to talk about Polycystic Ovarian Syndrome. Yes, if you find this video useful, please share it to your friend. You could subscribe, you could give us a thumbs up, comment. I've seen all your comments and I thank you. Yes, it will help us improve. Now, what we have to understand is the fact that polycystic ovarian syndrome in ladies is as a result of an abnormality in the metabolism of the androgens and estrogens and in the control of the androgen production. Also, polycystic ovarian syndrome can also be as a result of abnormal function of the hypothalamic pituitary ovarian axis. The pituitary produces the two hormones, follicle-stimulating hormone to stimulate the follicles to mature, and luteinizing hormone to lead to what we call ovulation. Now, in polycystic ovarian syndrome, these ladies have a high surge of luteinizing hormone, leading to what we call anovulation. Now, these immature, or actually the immature follicles, naturally they have to be denatured, but what happens is the fact that they remain inside the ovary as fluid sacs, or what we call cysts. And in order to diagnose polycystic ovary, you should have 20 or more cysts. Now, this luteinizing hormone can also, in turn, in these ladies we have insulin resistance. Now, the luteinizing hormone, the increased levels together with the increased insulin levels can also lead to increased testosterone production. Testosterone production then also leads to infertility, virilizing signs. Polycystic ovarian syndrome, this can also be referred to as Stein-Leventhal syndrome. Polycystic ovary, we have polycystic ovarian disease, hyperandrogenic chronic anovulatory syndrome. We have functional ovarian hyperandrogenism. It is associated with marked increase in ovarian androgen production and also insulin resistance, and is one of the most common endocrine disorders in women, affecting approximately 6% of all women during their reproductive life. Although the pathogenesis remains uncertain, insulin resistance and hyperinsulinemia are found in approximately 80% of the affected women. There is no universal accepted definition, but it has been recommended that diagnosis of polycystic ovarian syndrome requires the presence of two of the following three features. One, we have menstrual irregularities, oligoamenorrhea, sometimes secondary amenorrhea, as we shall be finding out. Usually the second feature, we have clinical or biochemical androgen excess. The third could be multiple cysts in the ovaries, most readily detected by transvaginal ultrasound. As I told you, they have to be 20 or more multiple cysts. So what we have to understand is the fact that some polycystic ovarian syndrome has different the syndrome can produce a lot of symptoms. For example, anovulatory menstrual bleeding, which is usually painless, irregular in occurrence, and also unpredictable in amount and also in duration. We have transient disruption of ovulatory cycles, which occurs most often in pre-pubertal years. During this perimenopausal period, or as a consequence of a variety of stresses and intercurrent illnesses, persistent dysfunctional uterine bleeding in reproductive years, usually due to continuous estrogen effects on the uterus, interrupted by cyclic fluctuations in progesterone associated with ovulation. Now, diagnosis of polycystic ovarian syndrome. Here we have a condition called acanthosis nigrans. This is a condition that causes areas of dark and thick velvet skin in body folds and creases, typically in the armpits, groins, and neck. We have enlarged ovaries. They may or may not be present, so you can evaluate. As we said, this is done using a transvaginal ultrasound. We have virilizing signs due to increased testosterone levels here, where we have ladies developing beards. Here we have the women develop male patterned hair growth and also masculine physical traits. For example, development of pubic hair in pre-pubertal children. This is kind of rare. Accelerated linear growth and also advanced bone aging. Hypertension is another condition we use to diagnose. The clinical features of Pcos, polycystic ovarian syndrome, we have pituitary dysfunction, and this is characterized by high surge of luteinizing hormone, and also prolactin hormone could be high. Anovulatory menstrual cycles, as we said, we have oligomenorrhea, secondary amenorrhea, cystic ovaries, and usually infertility. Actually, most of them, there is infertility. Androgen excess leading to hirsutism and acne. Obesity, this is characterized with hyperglycemia, increased estrogen level, which may cause endometrial hyperplasia. We have dyslipidemia and hypertension. Sleep apnea, and these patients with Pcos, they usually have sleep apnea. They wake up gasping for air or even choking, wake up with headaches, and more of such. Management. Now, what we have to understand is that in management of polycystic ovarian syndrome, we manage the symptoms. We manage the symptoms, and also we help these patients to improve on their fertile life. Usually, lifestyle modification is the key. Remember, these patients are prone to diet, so we have to cater for their diet. These patients should carry out exercise and also endure to lose weight. Pharmacotherapy, this is reserved for the so-called metabolic disarrangements, e.g. in anovulation, menstrual irregularities. The first-line therapy usually consists of an oral contraceptive to induce regular menses. Here we could also use ethinyl estradiol, medroxyprogesterone. We have in cases of hirsutism, here many patients use shaving. We can use bleaching and waxing. Electrolysis and laser treatments are also very effective but expensive. Eflornithine cream may also reduce hair growth, but if such symptoms are not alleviated by what we used above, we could go in for an androgen blocking agent. Androgen receptor antagonists such as cyproterone acetate, 5-alpha reductase inhibitor such as finasteride. This prevents activation of testosterone. Spironolactone, this is used off-label in women with hirsutism and hormonal acne. Yes, so when fertility is desired, here the first line treatment for ovulation induction, we use clomiphene. That is a selective estrogen receptor modulator, 50 milligrams every day by mouth, initially for 5 days. Hypoglycemic agents, we have metformin. This reduces insulin resistance and can also restore regular cycles. And what we have to note is both metformin and thiazolidines, they attenuate hyperinsulinemia, ameliorate hyperandrogenism, induce ovulation, improve on plasma lipids, but they are not approved for this indication. Now, if someone has acne, what we can use, we have benzoyl peroxide. This one, an example, we have benzox cream, if you know it. Then we have tretinoin topical cream, which is in a percentage of 0.02 to 0.1%, or it could be a gel in a percentage of 0.01 to 0.1%, or a solution of 0.05%. Adapalene topical cream, it could be 0.1%. A gel could be 0.1 or 0.3%. A solution could be 0.1. Erythromycin topical 2%. We have clindamycin topical 1%, and also sodium sulfacetamide topical 10%. So now if all those fail, then that means we go in for surgery, and the surgery is aimed at restoring ovulation. What we have to understand that we have different procedures we could take. We have what we call electrocautery or what we call thermocautery. Now this is just a process in which a direct or an alternating current is passed through a resistant metal wire electrode, generating heat. Now this heated electrode is then applied to a living tissue to achieve what we call hemostasis or varying degree of tissue damage. We could also have laparoscopic ovarian drilling. This is where the laser or the electrocautery, the one we talked about above, is used to destroy part of the ovary where testosterone is produced. As I told you, testosterone is also a leading cause of infertility, that is anovulation. So when we destroy these parts that produce testosterone, that means we can improve on this lady's fertility. We have multiple biopsies. The doctor could take up a biopsy to check or to confirm if this is polycystic ovarian syndrome. Now, what we have to understand is the risk factors for polycystic ovarian syndrome. These include type 2 diabetes, heart disease, cholesterol abnormalities, or endothelial cancer. Terms we needed to come about: we have anovulation. This is when the ovary do not use an oocyte during menstrual cycle. Oligoamenorrhea, this is irregular and inconsistent menstrual bleeding in women. Amenorrhea, this is the absence of menstrual periods. So if you find this video useful, if it has made sense to you, if this video has made sense to you, please consider subscribing. You could share it with other people. You comment, tell us where we need to tackle next. See you in this video. Bye bye.